Well, good day, everybody. My name is Martin Kiernan, and I'm pleased to welcome you to this episode of Infection Control Matters, which is going to be talking about an organism formerly known as Candida auris. With us today are Colin Brown, who's Deputy Director of Emerging and Epidemic Infections at the UKHSA, but he's also Honorary Consultant in ID and Medical Micro at the Royal Free in London. Andrew Borman is the Acting Head and Consultant Clinical Scientist of the National Reference Laboratory for Mycology in Bristol, and also Honorary Professor of Medical Mycology at the University of Exeter. And Mariyam Mirfenderesky is a consultant in medical microbiology and ID with a lead of antimicrobial stewardship at North Middlesex, and also works at UKHSA as well. And we're going to be talking about C. auris, as I mentioned. But firstly, welcome to all of you, and thanks very much for agreeing to do this.
Thank you.
You're welcome.
Thanks for having us.
Secondly, I want to ask why the rebranding, because it has a new name, and it's, I'm still struggling with Clostridioides and Enterobacteriales. So, Andy, do you want to shoulder the blame for the change of the name
Yes.
to Candidozyma, or what's different about it? Let's get that one out.
I will
straight away.
explain why, but I'm not shouldering the blame for that one. But we've known for a long time that Candida is a bucket genus containing lots and lots of unrelated species or distantly related species. The analogy is a bit like your top drawer in your kitchen cabinet, which is supposed to have cutlery, but it also has elastic bands and broken things. And so the rebranding is to reflect the fact that it's loosely related to Candida, but it's actually sufficiently distinct to merit its own genus name. So luckily it's being called Candidozyma, so we can still speak of C. auris, but it's to make the distinction that it's not a Candida really, and it differs from Candida in quite a few different ways.
Okay, yeah, I'll start with C. diff for obvious reasons, because it's much easier, and there's always a controversy about difficile or difficile as well. So we won't go down that route. So why is it? I mean, we say emerged. It seems to have appeared all over the world at a similar time, although people are picking it up at different rates. What's do you think driving this increased incidence? That's
one of the really big questions, and it's a really interesting question from a purely fundamental mycology point of view. We generally don't know. It's been around obviously for millions of years, and sometime the last 30 or 40 years, according to best estimates, it's decided that humans are quite a reasonable niche, and it's made the jump from whatever environment it's occupied into humans simultaneously across virtually every continent. And we can speculate that people have suggested that global warming, that there's a lot of, almost all isolates of C. auris are fluconazole resistant. So there's the idea that perhaps fluconazole and other related drugs in the environment might be selecting for it as well. But we generally don't know what's caused this simultaneous emergence. It's fascinating.
Yeah, I was just wondering if it was something triggered a virulence factor that maybe was not there previously, which is now why we're interested in looking for it, because it's now causing us an issue.
It's possible. I mean, we've gone back. We have our own culture collection here in Bristol, but there are similar ones across the planet. And various groups have gone and looked at historical isolates in their culture collections. And there's the odd case that predates sort of 2009, but not really. It really generally has emerged in humans. And it's not just that we couldn't detect it or couldn't identify it before. It's a novel pathogen.
But it seems very unlikely that would happen, concurrently in multiple different clades, in multiple different continents. As Andy says, it's a fascinating, esoteric question, about why they all emerged. Is it the use of, fluconazole? Is it, temperatures within kind of healthcare, settings? The like high salt content, is there some change in, the way that we kind of manage patients that it's allowed, to develop in moist, hot, kind of warm, salty environments? But I don't think there's a convincing explanation that has been demonstrated about why.
No, I'm yet to be convinced about where Staph capitis has suddenly appeared in virtually every neonatal unit on the planet as well. So there's a few interesting things going on there. So why are we worried about this then?
Exactly, but at least with Staph capitis, you could say that there's a clonal element that's going around the world. So there is at least a sort of putative mechanism there. Whereas here we've got very, very, very genetically different clades emerging in multiple places all at once. So even more strange.
Okay. So why are we worried about it then? Why should we be concerned about this?
Well, that's another one of the things that separates it from most other Candida species, is that it is very, very readily transmissible. I mean, there are Candida parapsilosis has been associated throughout the years with small outbreaks, especially in vulnerable people like neonates, and we know that it can be transmitted on the hands of nursing staff. But we've never seen anything in the whole genus Candida that behaves quite like auris. It colonizes patients to extremely high levels. It's not a gut commensal like most other Candidas. It's a skin commensal, and it's shed in extremely high quantities from colonized patients into the environment, where it persists for a long time. And so you get very, very efficient patient-to-patient transmission. And in a hospital setting, that can be quite devastating.
Yeah, I mean, the only outbreaks I've seen of other Candida strains are normally practice related. People aren't looking after their lines properly or something like that. But it's really not like this at all, is it? I mean, talking about the sort of infections it causes, then who are the people at risk, and what are the main portals of entry of concern? I get that plenty of people colonized, but how are we getting in the infections?
It's mainly the at-risk patient groups are those predominantly that are on ITU for a long time. It's not the very immunocompromised patients, like the hematology patients, really, with at least not yet with Candida auris, because it's not a gut mental. So the normal risk factors for acquisition don't really count. It's a skin colonizer that gets in through lines, basically, is the predominant source. But also, we've seen it causing urinary tract infections quite frequently, and that is a potential sort of prelude to candidemia as well. And the sorts of infections it causes, it disseminates like all other Candida species do, or related genera. It's fungemia.
So again, potential for practice to prevent infection, going from colonization to infection, is there then, isn't it?
There are definitely enhanced line care, etc., and those sort of bundles are things that have been advised for a long time.
So if you look at one of the first outbreaks we had, it was on a neurosurgical unit, so they're having neurosurgical, shunt infections, and so in terms of why we are very concerned about it, even though, and I think we'll come on to this in the UK, the mortality is thankfully limited. There has been considerable morbidity and increased length of stay and exposure to toxic drugs to patients. And why we worry about it is, if you look at the Latin American clade, for example, there they've seen pan resistance. So they got resistance to both polyene, so ambazone, and also echinocandin, so caspofungin or nidulafungin. And therefore you remove all of our antifungal options. And should we be in a situation where we develop that in an immunocompromised, already challenging for infection community like intensive care, or particularly, let's say, a hemato-oncology unit, you could see and it's not only endogenous to them, but it's spread person to person, much like MRSA, so it can rapidly spread around the unit, and it's got persistent in the environment for a prolonged point of time. You suddenly get into a point, maybe not at the moment, but in the future, whereby you got an organism that is really difficult to treat, that does have considerable mortality associated with it if we don't have any treatment options, and very difficult to get rid of, and it can develop resistance in the face of being on treatment. So you can start with one set of resistance profiles and end with a much more worrisome one. So it's for those reasons in particular that we're concerned about it.
What contributes to low mortality then, Colin? Do you think that's rapid diagnosis and faster control measures, or what? Why do you think in the UK you say mortality is low?
I think it's difficult to know. When you look at the global literature, particularly the sort of early days of Candida auris, you see very high mortality rates reported of patients affected, up to 30, 40, 50, even up to 60%. What's never reported in those settings is the background rate of mortality in those units. So a lot of them are from intensive care units, quite often in resource, kind of intermediary resource to resource per settings, and so we don't know what the background rate of mortality is there. And also, we don't know necessarily what the access to, do you have access to ambazone? Because if you've got a caspofungin resistant isolate and you don't have access to ambazone, your treatment options are incredibly limited. So I think it's probably most of ours are colonizations where they are infections. We've always in the UK at least had one treatment option that's been effective, and it's one that would be within the standard arsenal of antifungal agents that people would be used. And we've got very good intensive care and very good supportive care, and so I think there's a variety of reasons why in the UK in particular we haven't seen necessarily considerable mortality. But the worry is about the future. And
Yeah.
what happens if you lose access to your two frontline options as well as your azoles? Like what do you do then? Or you get into a different population. It's been on intensive care. We've had vascular patients, we've had cardiothoracic units, we've had, as I said, the neurosurgical unit. What happens when it gets into a heavily immunocompromised, or very, very vulnerable, like a neonatal unit with widespread, in not just colonizations but infections? That's the big worry.
I think we're lucky in the UK that we've got access to all of the main antifungals. Definitely some of the lower and middle income countries that had outbreaks initially with high mortality, they didn't have access to, for example, things like the echinocandins. And also we've always taken these infections very, very seriously, and we treat them very aggressively, often with multiple antifungals. But as Colin says, if we start to lose a proportion of that armamentarium, then we're in serious trouble.
Yeah, sure. Can I ask you then about laboratory detection, Andy, and how you go about dealing with a screening swab in the lab?
That very much depends on individual centres and what their preference is. We're quite lucky that over the last decade or so, we have developed, not us personally, but the world has developed a number of different parallel screening approaches, all with their different merits. There are now very, very good chromogenic agars, which have been developed specifically for Candida auris or Candidozyma auris, where you can't identify it formally on the basis of its appearance on these agars, but it's a pretty good indicator for ruling out all of the normal other things. There are real-time specific PCRs, both commercial and in-house ones. So different centres are using molecular approaches to screening on swabs. Other centres are doing a commercial chromogenic agar. There are other selective media that have been developed. For example, CDC published a while ago a combination of high salt, high temperature, which selects specifically for auris. So we've got a fair number of good ways of detecting it now. And most or all labs that have different MALDI-TOF platforms, at least the two major platforms for proteomic identification, they have got the profiles for auris in there now. So we can robustly identify it using the more common methods that are available.
So you're pretty confident the clinical labs in the UK will pick this up?
Actually, I think while we do have access to excellent diagnostics, it's important to, I think, note that 3/4 of English organisations, NHS organisations, haven't seen this organism yet. And we are concerned particularly about the ability to work up Candida isolates to the species level. So a lot of laboratories will not identify Candida beyond Candida. And so we're worried about silent transmission, and certainly the outbreaks that we've seen in the UK, almost all of them have started from that way. So there was unknown silent transmissions. There is a huge differing capability and capacity to detect across the UK. So while we may have excellent diagnostics, particularly in London and some of the major teaching hospitals, that is not the case in the rest of London. And there are still, amazingly, laboratories that have no access to MALDI. And if you don't have MALDI, then you really cannot detect and respond to this organism. And at the minute, there is a questionnaire that's being sent through the ESPAR antifungal group to try and look at the state of diagnostics. But that does concern us. And having really good laboratory diagnostics is key to dealing with this organism.
And do you suspect some are slipping through the net then, just going out as Candida species because they're a contaminant or something like that? Yeah.
Completely. So we know that there's probably a huge ascertainment bias, that we don't detect particularly a lot of the colonizations. We also know that there are outbreaks that haven't been reported. And on the 1st of April, C. auris is now a notifiable organism. So there's a sort of a mandatory need for organisations to report through SGSS, and certainly to report if they have transmission. So we hope that will improve as time goes on.
That's only if they find it, though. Colin, you wanted to say something on that, I think.
I was just to say about just fungal diagnostics in general. I mean, I come from, luckily my hospital's had a long-standing interest in fungal diagnostics. Many hospitals or laboratories are not so fortunate, and I think compared to bacteriology, mycology, I mean, Andy might come in here, is a very poor cousin in the wider NHS, particularly for maybe not even for the identification, but certainly for antifungal susceptibility testing. And so there is a real bottleneck of what can be done. It's also why it's very important, if you're not familiar with that, to make use of a laboratory such as Andy's Mycology reference laboratory for that specialized work. Andy, I don't know if you want to say.
No, I agree. I think in terms of and at all levels of microbiology, whether it's funding from the major funding bodies, mycology has always been the very poor distant relative. And I just wanted to pick up on what Mariyam was saying as well. And again, because of how different this organism is to most other Candida species, it really requires a bit of a fundamental practice change, because most centres wouldn't even dream of identifying a Candida or a yeast to species level if it was just picked up on the skin. So Mariyam's absolutely right. And most of the outbreaks we've seen, it has always been a case of the horse has bolted. You've got the organism because you get the first bloodstream infection where you're forced to identify it, and then you realise that the whole place is painted with it. So that's the thing. We've got good methods of identifying mostly, but it's about whether centres are aware of the need to identify these superficial isolates, so to speak.
And there is the peak, isn't it? Bloodstream infection would be the peak of something. So when you've got that, you definitely got spread. Yeah, absolutely is. And I'll maybe come on to talk about outbreaks in a moment. But for screening, then, Mariyam, say in your unit you've got a bloodstream infection. You actually identified this as the correct organism. You're going to go some screening. I would personally think on case one, rather than waiting for evidence of spread. What screening are you going to be doing for patients and contacts, and how far do you go with the contact tracing?
Yeah, so just to take your situation, you have an isolate on an intensive care setting. So what we would say in that circumstance is that you would undertake a point prevalence screen, and certainly there's accumulating evidence that if you are aggressive in your screening approach, that's much better than sort of waiting for the numbers of cases to mount up. So what we would recommend, particularly intensive care, augmented care settings, and many people who have experience with this organism would do it on any general ward, is to conduct 3-point prevalence screens 24 hours apart across the whole unit, so that you very quickly have an idea of your burden. We talk about contacts. So we mention in the guidance that you can de-isolate your contact if they've had 3 negative screens 24 hours apart. Just to say, in terms of caveat regarding that, we've had some feedback, particularly from organisations that have outbreaks or quite large outbreaks, that often those contacts are designated negative, subsequently become positive, so either days or weeks after. Now, the question is, did they miss on the initial screen? It's possible that just the burden in the environment has built up, or transmission through patients, equipment, healthcare workers, and then they become positive. So if you are in an outbreak scenario, not only do you need to do your point prevalence screening, but then you need to set up some sort of onward screening. And that could look like admission screening, weekly screening, discharge screening, and it will really depend on the burden, where you are in your outbreak control measures, and what's right for your patient cohort.
I mean, any screen's only as good as the bit you touch with the swab, though, doesn't it? So if you've got ecological niches on the skin, you could potentially miss them. And it may also depend on what you've done to try and, is there a way of actually helping someone become negative if they've been positive on the skin? Because I've read papers that suggest cloextine looks all right in a lab, but not necessarily in clinical practice. Where do we go with that one?
So just in terms of sort of long-term colonization, I think Andy alluded to this earlier. I'm not aware of any sort of guidance or international publication that would de-escalate a previously or a currently positive patient. Colonization, certainly from the evidence, is prolonged, and that's months.
We've seen years, yes,
or
absolutely.
Months or years. CDC says at least 3 years, and that's what we've put into the guidance. We would never recommend de-isolating a positive patient. There's a controversial sentence in the guidance. When we went to the back and forth with the working group, and Colin can attest to this, about when could you take a positive patient out of sort of isolation, and what we've put in the guidance, and I think we're probably the only international or the only organisation to do that internationally, is if you have a patient who's negative, repeatedly negative, and that's not just after 3 screens, that's months or years, then you could possibly take them out of isolation, but you need to undergo surveillance. So again, a weekly swab, and depending on the acuity of the patient and where they are in your organisation, you need to be very careful, because they it just may re-emerge, particularly if there's a selection pressure on that individual.
So
I mean,
if you're tagging people and they go home, you keep the tag so
Yes.
that when they come back in, they go into isolation,
Always.
which is fine in your
Absolutely.
hospital. But if they leave the Royal Free and get admitted to University College, then they're not going to be tagged there. That's potentially an issue.
There's a wider issue there, isn't there? But it would be ideal to have tags that follow patients, through their healthcare journey, wherever they go, primary or secondary care. I mean, I think, we've seen someone positive after 4 years. And the point that Mariyam, talks about in the guidance is there for experienced centres that have had a lot of it and kind of know the boundaries of where their transmission events, etc., are to think about, de-isolation. Sorry, I maybe interrupted what Mariyam was about to say, but we know that you can go negative probably once you're off your intensive care stay, once you're off your selection pressure, you recolonize your gut with your normal microbiome, but then you come back into hospital and you get further broad spectrum antibiotics, and a week, 2 weeks, 3 weeks down the line, you can end up being positive again. So that's the situation we're trying to avoid, is those people, not being flagged, not being isolated at the start, and then seeding a whole new outbreak, several years later, because someone has thought, their initial screen is negative and therefore everything's fine.
Okay.
But, Martin, just to come back, you raise a really important question, and in the guidance we do recommend screening patients from affected units. But how does one organisation know that another one has got an infected unit? And there is quite a lot of work undergoing at the minute. So UKHSA has set up a national incident looking into auris, and one of the difficulties is this information sharing across organisations. So if one, or how do organisations know? And we are looking at trying to augment that information sharing. One thing we always say as well is for the patients that they really know and understand their infection status. They should be given, it should be on their discharge summary, they should be aware, they should be given a patient information leaflet. Some units give a type of infection passport, if you like, so that when they present to alternative healthcare practitioners, that it will say what their status is and what they need to do. But there's a lot of ongoing work, I agree with you, that needs to be done in that area.
Just want to expand on what Mariyam was saying as well, because a few things have changed with the guidance over the years. And we used to have a situation where we had certain endemic countries, which are the ones where this organism had emerged. All of that changed really during the COVID pandemic, which allowed auris to seed itself across the planet. So the other way in which the guidance has changed is not just to UK affected hospitals, it's basically any patient that's been hospitalized abroad, because we know that this organism's rife in Turkey. There are big outbreaks in Greece. We're seeing quite a lot of patients returning from Turkey after cosmetic surgery, where they're coming back colonized. So it really is, the planet has changed quite a lot in the last 10 years or so. But Europe is a hotspot now.
Yeah, I'm going to chuck a left field question in now. We've seen in the past, when in the good old days when MRSA was a superbug, that you would get family contacts positive. Given that people get extensively skin colonized with C. auris and it does spread into environments, is there any evidence that family members living in the same household may become colonized? Has anybody looked?
So
community.
Sorry.
Oh, sorry, Andy, you go ahead.
Well, no, I was good. I don't think anybody has formally looked. It's another question of sensitivity of the testing, as Mariyam and Colin said before. I'm sure it's likely to happen. It must be spreading in the community and then within dwellings, etc. But when in otherwise healthy patients who are not being poured antibiotics, we're just not probably able to detect it. They're colonized at such low levels that you're probably not picking it up.
And you've never screened them anyway, so yeah. Okay.
You wouldn't, and it's impossible that all acquisitions take place in hospital, because somebody has to transport it in the first time. So it must be spreading in the community, but I don't think we're well placed to be able to do that sort of study or to be able to detect the levels that they might be carrying it.
Okay, can I also ask, are there any differences in the clades as well, in the amount of colonization and persistence? Because I know they behave quite differently, don't they? Some seem to cause more acute infections.
Yeah, there are likely to be. I mean, we've published extensively on the different clades and how they behave differently. Some of them grow as single cell with limited budding, and they seem to be much more capable of causing invasive and disseminated infections. They're more virulent in a variety of models than other clades, which sort of grow like large aggregates. And definitely those clades, there is indirect lab evidence and also theoretical evidence that they would be much better at surviving in the environment, because they basically grow like an artificial biofilm. So we know that prevents antifungal drug penetration into the heart of the clumps. We know that it renders them more detergent resistant as well. So one would speculate that those, although they might not be as pathogenic in the patient, they would likely be more resistant to the environment and probably more prone to spreading. So those, for example, the clade that originated in South Africa is one of those that we would predict is probably better at surviving in the environment.
Is there a benefit then to knowing which clade you're dealing with then when you're dealing with an outbreak?
It's sometimes a useful additional piece of information. I don't think it really would change any of our IPC or other recommendations, because they're all pretty nasty if you get them in a healthcare setting. So,
okay.
I think if you've got an outbreak, you've got an outbreak. So
no, fair enough.
The clade doesn't particularly. I mean, to your point about the community transmission, I mean, it stands to reason within households, just like PVL, MRSA, and other, skin to skin bugs that, we know that it can be, when you look at kind of bed changes, you can get it in the air. So, I mean, it stands to reason that in a heavily contaminated environment, there is some transmission. What we don't know is how contaminated people are when they're not in healthcare, and there's the selection pressure on it. So there's a whole variety of research questions that are being posited as a result of the national incident that Mariyam talked about, of which that is clearly one. The bit of work we did do recently was an MDRO general community survey called AMR in the community, which we're just in the final stages of writing up. We looked at a variety of different organisms: CPE, ESBL, MRSA, and C. auris, of which there was no C. auris among 2,000 patients, or not patients, members of the population from across the UK. But to do a proper survey to arrive at a proper point prevalence estimate, you would need to test so many people that it just would be unfundable. I think
unwieldy. Okay. We know then, Andy mentioned it survives well in the environment. Mirfenderesky, can I ask you to talk about transmission in the healthcare environment and what we can do then to reduce environmental contamination or minimize the risk from it anyway?
Yes, of course. So we know that the main routes of transmission are patient to patient, but also indirectly either through the equipment, the environment, or healthcare workers. Healthcare workers spread tends to be transient. It's not that you've got this burden of chronically colonized healthcare workers, but transient on the hands. In the guidance, there's a dedicated chapter to IPC. It's the largest chapter in the guidance, and it really goes through it outlines 10 what we call IPC measures that a trust needs to consider to manage this, from transmission-based precautions, predominantly contact precautions, really important to have scrupulous hand hygiene, and then patient and contact placement. So ideally in a side room using ensuite facilities, cohorting if necessary, dedicated staff if you can, and particularly in an outbreak setting. But then really the importance of effective cleaning of equipment and the environment. And that brings us on, I suppose, to effective agents. And that when you're thinking about C. auris, you have to use an agent that we know that is going to be effective against that organism. 1,000 parts per million of chlorine is effective. We advise against quaternary ammonium compounds, which are actually quite widely used in the NHS, and that's just because we're not assured of their efficacy. There are other disinfectants that are used, particularly paracetic acid, that a lot of trusts use in outbreak situations. Really important to follow manufacturing instructions, contact time, which can actually be really significant.
Yeah, very significant.
Prolonged periods of time. Some of them are 7 minutes. And then again, depending on the formulation, the biocide concentration. If you are going to use supplementary measures like hydrogen peroxide vapor or no touch irrigation systems, that these are, as I said, supplementary, and really the importance of adequate cleaning and disinfection cannot be overestimated.
Yeah, I mean, it's back to elbow grease, a lot of it, isn't it? Because you have to clean first if you're going to be able to disinfect. And, I get your point about quaternary ammonium compounds. To me, that term is a bit like the cutlery drawer. It's a formulation, so it could be anything. And
Yes.
you need to go to the manufacturer of each individual one to say, what are you doing? And what's your test data like? And is it a solution in a lab, or is it actually on a surface? So, yeah, it's not.
Yeah, I
robust.
mean, that's a really good point. And it's difficult actually for IPC teams in the UK. If you look to our colleagues in America, so the US Environmental Protection Agency has a list of registered disinfectants that are effective against C. auris, and those have undergone testing against a standardized methodology. Some of those are used in the UK, but not all. What we do say, though, is if your agent works against C. difficile, then it will likely work against C. auris. But be careful against claims of Candida. There are other Candida species that are much more susceptible.
Other Candida are available, yes. Yeah, absolutely.
But as a general rule, if it works against C. difficile, it will likely work against C. auris.
Yeah, I mean, our listeners in Australia will be familiar with their EPA as well, so they have a test like the Americans do. So that's a little bit more robust, I think, than just relying on what the manufacturer tells us then. Okay, let's go on to outbreak management then. The key measures are presumably patient isolation, rapid detection and screening, but what else we've got there, Mariyam?
Really, I can't overestimate the importance of having robust diagnostics. And this has come out. So, if you're dealing with MRSA or you're dealing with CPE, a lot of IPC teams will assume that they have good diagnostics. That is absolutely not the case in C. auris. So if you are an IPC practitioner, you need to work with your laboratory to understand, first of all, can you detect it, and then which sample types, and then can you screen? Because if you don't have effective screening method, I would guess that a lot of, if you're not doing routine screening in the NHS, they won't have access to chromogenic agar. So if you find yourself in an outbreak, you're going to have to rapidly upscale your diagnostics. And then almost all and we've had at least 5 outbreaks in the UK, in England, that have had more than 50 cases. Our 2 most recent outbreaks have over 100. And both of those have had to implement PCR. And we don't put a recommendation in for PCR, but when you're getting to, large numbers, you need that rapid turnaround time, and you just can't be doing with the 72 hours plus that you need with culture. So for me, it's about rapid and good diagnostics, very aggressive screening policy to take the organism seriously. So you'll be really surprised, particularly among some of our IPC practitioners and clinical colleagues, about what's the fuss about. And some of the feedback we've got from people who've managed outbreaks, if they wish they took their first, second, third case much more seriously. And what we say in the guidance is that even if you have one case of suspected healthcare associated infection, that you stand up an incident management team. And that may not be the process for CPs, for example.
No. Absolutely. I mean, it's interesting, isn't it? Because you could actually have more than one outbreak going on, of course, because I remember the cardiothoracic incident in the Brompton. They had 2 different clades kicking around there, and it was only through outbreak investigations they came across that. I'm presuming, Colin, from what you said earlier, if you've got an outbreak, it doesn't really matter about the clade. If you did have an outbreak with multiple clades, it would be fine to cohort if you have to go down that route with different clades together, because the principles are going to be the same. Would that concern you at all?
No, not cohorting of the same clade. I mean, I think, as you say, and we've seen it several times actually, that and Andy's being able to prove this, that there are being multiple introductions to in fact many of the hospitals that have had an ongoing outbreak, and it can be really quite challenging to tell therefore what's an introduction versus a transmission event. And I think that has got obviously IPC implications, but not necessarily from if they happen to all be together. It's more recognition of the problem, recognition of the scale, widespread screening, make sure people speciate all their Candida, they look at all the shared equipment, which has been a big issue throughout all of these. outbreaks, whereby the more you look, the more you see, you know, mobile bits of equipment that are really tricky to properly decontaminate. And because it's a skin bug, you know, if you've got a probe, if you've got an ultrasound lead, if you've got, I mean, in the famous Oxford outbreak, it was auxiliary,
temperature
thermometry
monitoring probes.
And they, you know, they just really, there's nooks and crannies in them. It's really difficult to even if you can, you know, use the appropriate cleaning product to get in there. And I think it's recognizing those potential transmission routes and limiting as far as possible any shared equipment, making sure staff are fully aware of the role. And I think, you know, to Miriam's point also about the, you know, the some of the trust saying why bother. It's a very real point for them, because you're telling people on one hand there's not much morbidity or mortality associated with it in the UK, but you're potentially shutting down entire areas because every hospital that's looked has found some issue that they need to improve on. A lot of it as being full revamps of ward closures, or at least ward area closures, with refurbs done. And, you know, that's an awful lot of money. It's a lot of cancelled operations. It's a lot of altered practice, and it costs a lot of money in addition to all the screening. And then trusts are going, well, why are we that concerned when you're telling me, you know, none of my patients have died from it?
Yeah.
And it's that difficult balance about it's more about the future. If it gets into a difficult environment, if it gets a bit more resistance, that suddenly it's it's an absolute game changer, and it's preventing that state. But it's a difficult argument to sell to stretch trusts with multiple competing issues.
Difficult to shift it though, isn't it? That's the problem. When it becomes really robustly ingrained into your environment, it's, you know, getting it out is going to be a problem.
Yeah,
it is,
absolutely.
Although we think every hospital bar one at the moment has managed to cease their ongoing outbreak. There's one hospital at the moment where there is a concern that it really is quite, you know, embedded within the environment, and the purpose also of the national incident is to try and see, you know, is that really true, or can we revert that course as well?
Yeah, Andy, you wanted to say something then, I think.
Oh, sorry, go ahead.
Yeah, sorry, I was just getting two unrelated points. I mean, I think pick up on Colin's comment about the different clades. In many cases, it's actually been reassuring to the local trusts that we can prove it's a new introduction rather than an abject failure of IPC. The IPC is working, you're just importing it frequently. So I think that's an important difference. Yeah, definitely.
Yeah, Mariyam, you want to make another point?
Yeah, no, sorry, just to say, there are organisations, particularly in London, who see a lot of CRS because they have this back and forth with international healthcare organisations and repatriations. They're really good, really effective. That when they see transmissions, they terminate it. And the key to that is being aggressive, having a really aggressive approach. If you allow your outbreak to gather momentum and then you get into the double digits, it becomes much harder. It becomes self-perpetuating. You've got increasing burden in your environment, healthcare worker exposure, environmental. If you get to the hundreds, then that's a really difficult situation because then you run out of side rooms, etc. So my advice to organizations is to be aggressive, take the organism seriously and trying to deal with it in single figures before it escalates, and do whatever you need. And I mean, Colin, it's a really expensive business. So there was a recent transmission in a neonatal unit. So just 2 cases in the neonatal unit, but because it's such a devastating cohort to have a CRS in, very aggressive approach, in excess of £80,000. The whole ventilation system needs to be reworked. But I think that's right and appropriate, and they stopped it at those numbers.
I think it's interesting is that it sort of highlights some of the IPC problems that probably would be best addressed anyway. You know, so you know, it's not like a lot of the money spent on the refurbs. No, absolutely, and it's not like a lot of the money spent on the refurbs were not worthwhile things to do. You know, to improve general IPC. What we haven't completely looked at is in units that have done that, have we seen reductions in other MDRO transmission? And that's something also to add to the future list to look at.
I think the other thing as well, which both Colin and Mariyam alluded to, is we're seeing it enter into slightly different patient populations in hospitals as well, which is posing all sorts of additional problems. And it's not several of the major current outbreaks are, as we've mentioned, are in vascular patients. They're mobile, so cohorting them or isolating them becomes a much bigger challenge than somebody who is in an ITU bed and not moving. So, and as Mariyam alluded to in the neonatal unit, the the more it spreads into these different patient populations, the more difficult it is to actually implement some of the IPC controls. You've got patients wandering around all over the place. And I think that probably contributes to why the two vascular outbreaks have been so protracted as well.
Yes. Yeah, the patients are much more mobile than critical care. Okay, let's look ahead then briefly, unfortunately. But Colin, I mean, you've listed about 1 million research gaps. What do you think the priorities research that we need to do to improve control of C. auris then?
So, I mean, there's the esoteric ones, which are very interesting and it might help in kind of, general understanding about kind of better control of MDROs in general. But I think for Candida auris, there's a couple of key ones. There's the individual patient end. What's the best way to treat infections or when you've got them, including combination therapies? There's the very important colonization question of once someone's colonized, is there a debulking or deburdening regimen that is effective or indeed might be curative? And we certainly don't know that. There's the environmental considerations about what's the best way to eradicate it from the environment, including from these difficult shared bits of multi-use equipment that are challenging to treat without dipping the whole thing in chlorine and rendering it ineffective. There's the where's the best screening point for it? Some of the current outbreaks, particularly is the one that Andy has said in this newer patient group, we're not really sure where exactly they've entered into that patient group. Whereas we see all the time people coming from hospitals overseas where they're screened, they're colonized, detected, and it's very clear cut. So where is the best intervention done in maximizing your bang for buck in screening? Do you do pool swabs? What's the is it just sort of speciating all of your candidates when you identify them, rather than instigating widespread upfront screening? So I think there's a whole bunch of questions around what's the best way to prevent introduction, or you're not going to prevent introductions necessarily, but recognize the early introductions, and get really effective IPC measures embedded, which is essentially making sure that patient is known positive, isolated, early on. And then there's a variety of sort of, as you alluded to, the sort of community transmission events and, what's going on, in populations where you've had a big outbreak, and how best you identify patients, again, coming in. But I think to me that, if I was going to invest in a couple of questions, it's what can you do with it? If, 3 ones, what can you do with it from the environment? What can you do with it with the patients once they're known to be positive? And what's the screening strategies to prevent control? Those are sort of the big unknowns, I think, and ones that we would focus on. I don't know, Miriam, if you've got.
No, you're right. And just the importance, I think, of cost effectiveness. So in terms of, outbreak response, I can say to be really aggressive, it's really expensive to have that approach. Yeah. So cost, and that was one of the things actually that delayed our guidance, our recommendations, who to screen and are they cost effective? And that's ongoing. And there's a piece of ongoing work that we're trying to facilitate with our modelers at UKHSA, but we don't have the baseline information and it takes years, but it's important.
Yeah. Okay. Andy.
Yeah, it's a more esoteric question, I guess, but as the reference lab, I suppose we're forced to think like that. It's more of a horizon scanning. What has caused the emergence of this? What's its natural niche, and where's the next one to come along? Because I don't think auris is unique. We published a new genus last year, something called cardiomyces, and we've not seen outbreaks, but we've seen infections with it. It's multi-drug resistant, and it has exactly the same profile as auris. It's a thermophile. It goes at 42. It loves salty seawater conditions. So why are all these things suddenly cropping up? And can we adopt also a One Health approach of trying to intervene in the environment?
Yeah, I mean, it's maybe the era of the mycologists. You never know. Bacteriologists may have had their day.
A time has finally come.
It's finally come. Well, if you wait long enough, generally things come around anyway. Well, thank you very much, all of you. I've really enjoyed doing this. I think, again, there are more questions than answers. I think, picking up what Colin said earlier, you're not going to stop it coming into your hospital because you don't know who has it, unless you're fairly sure somebody's coming from an area that's endemic. So it's detect it quickly and then act quickly. I think those are the key take-home messages.
Absolutely.
And in particular, if you have mechanisms, I mean, at the very least, have mechanisms to understand if you're seeing an unusual number of candidates that are unspeciated, because I think that's the worry we have, is that there'll be a unit where actually, I mean, let's say the diabetic foot where candidas are very, very common. Have you got enough understanding that you're seeing maybe like double the amount that you did in the previous months, so that some of those can get speciated, so that you can pick up, because I think what we've seen absolutely is just the earlier the intervention, the better. So just wherever possible, think about where are the missing gaps in your current diagnostic pathways that mean that you might be missing a problem that you already have.
Okay, so if you're an infection prevention control team member anywhere in the world, go and knock on your lab's door and say, can you actually look for this, and how would you let me know? I think that's a key point as well. Thanks very much for joining me, everybody. And to all our listeners, thank you very much for coming along, and we'll catch you again on another episode of Infection Control Matters. Goodbye.
Thank you, Martin.
Thanks very much.
Thank you.